over again.
Yes, start over.
Well, let me just talk over this and I'll move on. Increase in P-trans, increase in stretch, increase AP frequency. So I mentioned this. Is this afferent or efferent? If it goes to the medulla. Then you get to the medulla, you mobilize the correct centers. So let me erase this now. I'll leave this term, cardiovascular center. What we want you to know are three subcenters of this center. Two are listed here, cardio-inhibitory, cardio-acceleratory. The third one is vasomotor. Those are the three centers you're expected to know. And so, basically, for the cardio-inhibitory center, what nerve is it going to use? Vagus nerve, cranial nerve 10. That'll go to the heart. What nerves do the cardio-acceleratory centers use? Those are sympathetic efferents. And they come off the level, think of where your heart is. T1 to T5. Those are the spinal nerve levels that have sympathetic efferents. So I'll just put SYM. There's no specific name. Sometimes they call them cardiac nerves, but it's at the level of T1 to T5. That's usually what I emphasize. Those go to the heart. Of course, they have opposing effects, right? Like, for example, if you want to, if blood pressure is increased and you want to drop it, I said you should use this center, right? Stimulate this one. Because if you want to drop the blood pressure, the effect of the vagus nerve is to decrease the heart rate contractility. That's what I said when I went over the reflex. But then, if blood pressure drops and you want to raise it, you want to turn on the other center and turn off the other center. Cardio-acceleratory center is supposed to jump your heart rate, increase the contractility, increase the heart rate, increase the cardiac output. So they have opposing effects. The heart has dual innervation. Okay. For the vasomotor center, it's all sympathetic, and you have them at every level that you have sympathetic efferent. So here's a picture to remind students of what we teach in autonomics. Right here. T1 to L2 at every level. They even say C8, but I don't think C8 has it. I think it's T1 to L2. These are all sympathetics to your whole body. Okay. Blood vessels from the vasomotor center have sympathetic efferents. T1 to L2, they're all sympathetic. The effect on the blood vessel is to go from a more dilated state to a more constricted state. So we call this vasoconstriction. That's very effective in the arterioles for increasing the blood pressure. If you want to vasodilate, you have to inhibit the vasomotor center. Okay? So blood vessels do not have dual innervation. You either just kind of increase the volume knob on the sympathetics or you decrease the volume knob. Okay? That's kind of how I think of it. They call it sympathetic tone. You don't have dual innervation. You just increase the tone to constrict, decrease the tone to dilate. Okay, that's kind of how you want to think of the vasomotor center. So, all these right here, you tell me if you're following this. Is that afferent or efferent? What's the correct term here for that? These nerves. Afferent means go into the central nervous system. Efferent means you go out of the central nervous system to effectors.
Efferent.
These are all efferent. Right? That's what I'm saying, because this cardiovascular center, it's in the medulla. So these are all the details I was trying to flesh out before the break, and these slides are just reinforcing it. Now let's shift gears a little bit. One of the things I present in class that we can't do in lab is choke out. Okay, it's not really safe to do. However, I caught a show where they actually tried to do it safely. They choked this guy out. And actually put some questions on your lab on it. Those are on your lab practical, and I have it all queued up here. I would like to watch that. I want students to see how the sympathetic responses respond while you're being choked out. And it's also good to observe how easy it is to choke someone out, how easy it is to starve the brain of oxygen during a choke out.
Force.
Wow. Yeah, it's just tightening up.
You notice he's wrong because the throat kind of brought it on.
But that's nothing compared to mixed martial arts legend Fedor Emelianenko. He clamped down with 500 pounds of force. So we know what squeezes harder, but what we don't know is how little force it takes to choke a person out. To answer that, we're using a different kind of dummy altogether.
I'm about to get choked out by the baddest man on the planet.
That's right. Earlier in the show, sports science host John Brinkus sacrificed his entire body going up against NFL All-Pro defender Chris Jenkins. Now John's neck is literally on the line.
John's in trouble. John's gonna go to sleep. And, you know, it's not a bad thing. I've been choked out many times. Only have a couple twitches from it now. It's not that bad.
The things I do for science.
We've rigged John up with sensors to show us what's going on inside his body as he's being choked out.
So this is a pulse oximeter. So what we're trying to do is we're trying to capture your heart rate, which will probably be high, and the oxygen saturation in your blood, which may go down, depending. So we'll see how the results are, but your heart rate will probably go up because you're stressed, and your oxygen will probably go down.
Do I look stressed?
A little bit.
You'll be okay. Don't worry.
Oh my God. I know, I'm just extraordinarily freaked out right now.
Our dummy John's all rigged up and ready to go.
Are you ready?
I'm ready. Are you ready? You're up to 136.
Oh my God.
A heart rate of 136 is almost twice as fast as the average resting heart rate, and we're just getting started.
Oh my God. Are you sure you're not going to crush my windpipe? All right, please do not hurt me.
We're at 141. Okay, John, are you ready?
All right, I'm ready.
Okay, Taylor, are you ready?
Oh my God.
3, 2, 1.
John's heart rate spikes to 180. He's redlining, experiencing a severe panic attack, and the oxygen going to his brain has decreased by 15%. But that small decrease is enough to put our host out. John's heart rate and respiration leap in a frantic attempt to get blood to the brain. And when that doesn't work, John's brain shuts down. The brain needs 50 milliliters of oxygen a minute. That flow to John's brain has been cut by 15%. And if it's reduced by only another 5%, it could be enough to put him in a coma, or even kill him. But Fedor releases his grip on John's throat. And blood is coming back to the brain. John was choked out in 4 seconds, and it takes him 4 seconds to come back.
Do you like it? Yeah, man.
Do I do it again?
Oh my God, I really don't want to do that again.
We know Fedor can squeeze with 500 pounds of force, but with John, he didn't need nearly that much. He only used 40 pounds of force. That's the same amount of choking power as the python. Medical experts say it takes as much force to compress the carotid artery as it does to break this egg. That's less than 10 pounds of force. Not only could Fedor choke 12 times harder than a python, he put our host to sleep in a few seconds. And what did he think of our new dummy?
I have nothing but respect for John, because to have it done on you, you get a different perspective than just watching me do it to someone else.
That's what we call taking one for the team.
I always wondered if that's what you would say. Anyways, I guess somebody translate that. Okay, let me, So it's easy to get choked out, basically, and starve your brain of oxygen. And you saw his heart rate spike without even being choked. He just knew he was going to be choked. Just the thought of it freaked him out enough to get the response.
I remember back in like 2007.
That was a long time ago.
Yeah, that kids were doing that just for fun.
Oh, I heard that.
Yeah, the choking game.
Yeah, it's not cool.
in the 90s.
Sure, something like that.
About 92. That was a thing.
A few more things here. So basically, in lab today, what we're going to do is the cold pressure test and orthostatic hypotension to see the baroreceptor reflex. And we're going to do other things too. We're also going to do exercise. Before I describe that, I want to remind you that I asked you to bring yoga mats so you can lay down comfortably, but you didn't have to. Whatever, however you figure it out, lie down, stand up, follow the procedure. Try to observe a drop in blood pressure. Hard to catch. But if you do, this data shows within the first 20 seconds. It takes a while to get a blood pressure reading, so you might miss it. You should at least observe a jump in pulse. That's much easier to take, okay? Let's see here. All right, other thing we'll do is to evaluate cardiovascular fitness with exercise. Now this will require 2 people from your group to do what's called the Harvard Step Test. Now they give some parameters for it. Basically what I tell this class is go outside, find a bench, find a tall curb, and just make sure that both of your subjects use the same thing, do the same test. And well, the procedure calls for someone who in your group who's well versus poorly conditioned, and I just think if you can get 2 people to do it, that's all you need. Just get 2 volunteers, okay? If it turns out someone is well conditioned and someone is not, it will be better for comparison purposes. The exercise is standardized so that each subject is doing the same amount of exercise at the same intensity, okay? Because the thinking is, if you're well conditioned, it shouldn't be much for you. It should be easy for you. Your heart rate shouldn't really go up that much because you're in shape. You might be huffing and puffing if you're out of shape. Hopefully you can hold out for 5 minutes. Okay, that's the thinking. And, I thought it would be good to watch. This is a very standardized exercise protocol, and I found a nice YouTube video that kind of gives students a visual on how it's to be done. And let me go over real quick.
Step testing is used for predicting cardiorespiratory fitness. Pre-exercise test guidelines include ruling out contraindications and determining proper precautions for participants with balance problems or those who are extremely deconditioned. Prior to performing the step test, the patient's resting heart rate is recorded. Resting heart rate is 66 beats per minute. Tools required for the step test include a stepper platform that is 20 inches high, a stopwatch, and a metronome.
You don't need a
Participant
metronome.
is then
Just try
instructed to step 30 steps per minute with the rhythm of the metronome. The test duration is 5 minutes or until exhaustion.
So that's good visuals. You kind of see this is what you're supposed to do. The same amount of exercise, the same intensity for both subjects. And let's kind of take a look at the data you're supposed to record. All right, well, basically pulse, heart rate for both subjects while seated. And here's kind of a table of what it's going to look like. Pre-exercise, get a baseline for both subjects. Do the step test, and once it's over, get a reading immediately, then 1, 2, 3 minutes post-exercise following the test. So this is all recovery time, okay? So what you're going to do is you have an index. The index works because look what you're doing here. Duration of exercise in seconds times 100, it's 5 minutes, right? Divide by times 2 sum of 3 pulse counts in recovery. You're taking 4 pulse counts. If I take the first 3, for example, all right? And the thinking is, if you're in shape, this should be a lower number in the denominator, okay? So if you're in shape and, well, if you're dividing by a higher number, the index will be lower. So basically that's why the index works. So if you fall somewhere down here, it indicates poor physical condition. This isn't the best way to do it, but it's a quick, easy way to do it. You just look at the recovery time, count the pulses, and see where your subjects fall. And that should be kind of fun to do. All right. Now the one I've been talking about, the cold pressor test, you should see a sudden increase in blood pressure, and the reflex should drop it. So I'm going to get some bowls of ice. See how the water is slushy? Technically, the protocol says 5 degrees centigrade, but I just think if you just make the water slushy, it's going to have the desired effect. Okay. You're going to increase the catecholamines, and whatever hand is submerged, put the BP cuff on the opposite arm. Sometimes students think you got to put it on the same arm, because you don't, right? This is a sympathetic, widespread, systemic response. Put it on the other arm for comfort, and the other arm will be submerged. You should, it doesn't matter which arm it's on, you should observe an increase in blood pressure, well, at least for the first minute. Get a baseline, and then for the 3 minutes, the entire time the hand is submerged. And on the other arm, you're taking readings at minute 1, minute 2, minute 3. Raise your hand if you kind of have experience using the BP cuff. A few people. And if you have someone in your group who has experience and you want to benefit from their experience, you know, if you have time after lab is over, kind of practice on each other. It's a good opportunity to do that. Of course, you can't keep inflating, deflating the cuff. The artery will start to spasm after a while. Well, anyways, the other thing you have to note, what you would expect is that a jump in BP at first, the reflex should tail it off by the end. Just see what you see, okay? Well, if you're a hyporeactor, you'll exhibit a rise in blood pressure 0 to 22. 23 or more, we categorize that hyperreactor. Okay? Because it's two numbers, diastolic, systolic, you could be hypo, hyper. Okay? Let's see what you get. So measuring BP, I want to make sure we're all on the same page. You put the BP cuff around the arm, you have all the musculature, and we're occluding the brachial artery right around there. Okay. And let's see here. We have a slide here. Okay. You know, let me show you the YouTube video on the proper way to take blood pressure, because I realize some people have done it, some people haven't. I want to make sure everyone in your group is on the same page, so bear with me. One more YouTube video. This will be better than me trying to go around in each group trying to show you.
Welcome to the Hypertension Awareness and Prevention Program at Yale. Today we'll be showing you a training video. My name is David.
And my name is David, and today we'll be showing you how to take blood pressure screenings. First, we're going to introduce you to the sphygmomanometer, or blood pressure cuff, and the stethoscope that we will be using to take blood pressure screenings. So this is the blood pressure cuff, or sphygmomanometer. The cuff is here, including the inflation bladder inside. This is the pressure gauge with the reading on it. And this is the inflation ball, which you use to inflate the cuff, and the valve, which you twist to control the airflow to and from the inflation bladder inside the cuff. This is a stethoscope with a similar design to the ones that you will be using in your screenings. The stethoscope has two earpieces, which should be twisted at a 15-degree angle. The earpieces of the stethoscope should be pointed away from your face, so that when they insert in your ear canals, you can achieve a tight and snug fit. The end of the stethoscope has two sides. One side is a bell and the other side is a diaphragm. The stethoscope can switch between the two sides by grasping the stem and twisting like this and like this. For our purposes, you want to be using the diaphragm. So make sure that when you look at the hole in the middle of the bell is covered. The stethoscope can only use one side at a time, and so when the bell side is covered, this means that the diaphragm is active. If you twist the diaphragm and the bell side is open, the bell side is active and the diaphragm is inactive. So for our purposes, make sure that the diaphragm is active and the bell side is closed.
For the most accurate readings, you should take the blood pressure of someone who has not drink alcohol or drink coffee or has done strenuous exercise before the reading.
And also make sure that you screen the person's blood pressure before they begin their meal. First, you want to orient your patient and prepare them for the blood pressure screening. Instruct your patient to stretch their arm with their palm up on a flat surface like a table, and have them expose their upper arm. If it's not possible for the upper arm to be exposed without constricting the upper arm or leaving it exposed for the blood pressure cuff, then ask the patient to remove their outer layer of clothing so that the cuff can rest directly on the skin of the upper arm. First, make sure that the cuff is fully deflated before beginning your blood pressure screening. To do this, place the cuff flat on a surface and Ensure that all the air has been evacuated from the bladder. Either the left arm or the right arm can be used. Have the patient extend their arm on a flat surface and rest it with the palm up at approximately heart level. Take the cuff and align the bottom edge of the cuff approximately 1 inch above the crease of the elbow. Ensure that the artery markings are facing up and wrap the cuff snugly around the arm, tightly enough that the cuff doesn't slide up or down. You want to align the artery markings, depending whether you're using the left arm or the right arm, with the space inside the crease of the elbow a little bit towards the interior aspect of the upper arm. Since we're using the left arm in this case, we want to align the left arrow just inside the interior aspect, just above the crease of the elbow. Orient the patient and let them know that they will feel tightness and discomfort in their arm temporarily as the cuff inflates. Ensure that the patient doesn't move the arm or talk as you're taking the reading. The inflation gauge has a clip, and there's a corresponding tab on the cuff where you can attach the gauge for easier reading and viewing. Now, you want to take your stethoscope, and again, ensure that the earpieces are angled away from you. As such, take the earpieces and place them in your ear canal to create a tight fit between your ear and the earpieces. First, position the diaphragm of the stethoscope against the skin just above the inner crease of the elbow, so that the surface of the diaphragm rests snugly against the surface of the skin, just below the lower edge of the blood pressure cuff. It's best to hold the diaphragm of your stethoscope with the middle and index fingers so that you don't confuse the radial pulse of your thumb with the pulse of the patient. Grasp the inflation pump in your right or dominant hand and use your thumb and index finger of your right or dominant hand to manipulate the air valve. First, you want to twist the valve all the way to the right or clockwise until you feel it stop. You don't want to over-tighten the valve because you want to be able to carefully control the amount of air escaping from the valve as you decrease the pressure in the cuff. So again, twist the valve all the way clockwise just until you feel a stop, and then stop. Begin by inflating the cuff to about 160 millimeters of mercury by squeezing the cuff, by squeezing the pump to 160. As soon as you reach 160, grasp the valve with your thumb and index finger and slightly twist it counterclockwise to begin allowing air to escape at a controlled rate. As soon as you reach approximately 160, you want to begin to allow air to escape from the blood pressure cuff at a tightly controlled rate. If you allow air to escape too quickly, you will miss the blood pressure reading. But if you allow it to escape too slowly, then you will cause undue discomfort to your patient. The reading at which you first hear the patient's pulse is the systolic blood pressure, and the reading at which you no longer hear their pulse is the diastolic blood pressure. As soon as you no longer hear the patient's pulse, fully deflate the cuff by turning the knob on the valve all the way counterclockwise.
All right, that's basically it. Let me show you that graph again. I'll let you guys do the lab. So the main thing is take your clothing off and put the BP cuff on the skin. I've seen students kind of like put the BP cuff over your long sleeve clothes. Like, what the heck are you doing? that basic you should all get. You put it on your skin. And the thing about the artery, because I didn't teach the arteries yet, you're going for this. Here's the brachial artery. It's on the medial aspect of the crook of the elbow. So that's kind of why you want to put it just above the crease of the elbow, more towards the inside, medially, because that's where the artery is. So that's the artery you're occluding. And here's why the heart sounds work. When you inflate to 160, you're assuming your patient is not, your subject is not hypertense. So you're assuming that 160 is a safe bet to get above the top number, so that when you listen for anything, nothing is going on because blood cannot flow. The artery is occluded. When you let the air sizzle out, as soon as the cuff pressure matches the actual systolic. You don't know what it is. It's 140, 130, 120, probably 130, 120, 100, something like that. Blood will start to pulse through. And it's pulsating because the artery is occluded, so blood starts to pulse through. And the first sound you hear, write it down, that is the systolic. And you hear this squirt, it'll get progressively louder. Usually they sound like tappings or thumps. And it gets louder and louder and louder, and then all of a sudden there's a huge drop-off in sound. When there's a huge drop-off in sound, or no sound, write that number down, that's the diastolic. The reason why you hear no sound is because laminar blood flow has been restored. Blood flow through your arteries is laminar. You shouldn't hear it. The reason why you hear sounds is because the arteries occluded throughout this time, right, between the high and the low number. Okay? So that's kind of the science behind it. Today's lab is due today. You, again, like the last time, you could turn in an individual report or group, and you may get started. Cups and stethoscopes are over there. Oh, I forgot one thing. Use alcohol wipes to wipe out the earbuds of the stethoscopes pre and post. Just want to say that.